I'm Larry Jameson. I'm the Dean of the Perelman School of Medicine. This is always a really exciting and impactful event. This is the 5th annual Basser Center for BRCA Breakthrough and Discoveries panel. Our panel has an interesting challenge. They need to take this fast-moving field with complex biology and help us understand what's happening in the field. There are patients and families and scientists in the room, and I'm sure they're going to do a wonderful job of that. Some of you will know that this is the 25th anniversary of the discovery of the BRCA1 gene. That's a complicated plot leading up to it, but it's just a reminder of the timeline of progress. And in those 25 years, the pace of progress is clearly picking up. The rate of discovery, the rate at which new treatment options are being identified with 4 FDA-approved drugs for this disorder in the last few years. You'll hear a bit more about that. And I think the scientists who are part of the Basser Center are really committed to the patients and families who inspire us. And we owe a real thanks to Mindy and John Gray for founding the Basser Center for BRCA. It's in recognition of the tragedy that affected Mindy and Sherry's sister, Faith, and it's their commitment that we move from that tragic identification of the disorder to trying to make sure that we can prevent it in others and develop better treatments, and that's what this symposium will be all about. So any effective center like this needs to have a great leader. And in the Basser Center, we have a terrific executive director, Dr. Susan Domchek, who is the Basser professor for oncology. And I'm not going to introduce the whole panel, but I did want to mention that our director of genetics, Katherine Nathanson, who is to her right, was recently appointed as the Pearl Basser professor. The Pearl professorship was supported by Sherry and Len Potter in memory of their mother, Pearl. She passed away a couple of years ago, was a giant in the Philadelphia community and really beloved by so many people. It's a great recognition of Pearl. But it also reminds me to mention to Kate that we expect you to be even smarter than you already are and do even more than you have in the past now that you have this professorship. So Susan, I'd like to turn this panel over to you, and we look forward to your comments.
Terrific. So thank you so much, Dean Jameson, for your continued support of the Basser Center, for fostering this culture of collaboration that we here at Penn, and that is really a key to our success. Thank you all for joining us today. This is also being live streamed, so it will be also available for later. As Dean Jameson mentioned, we're really here today because of the terrible loss of a family, but also their generous response to it. So thank you so much to Mindy and John Gray for their generosity in founding the center, to Len and Sherry Potter for their generosity in founding the Global Prize, and also Kate's recent professorship, and so many of you who have, because of things that have happened within your families, been generous donors to the Basser Center. Before we begin, just a little bit of housekeeping. We asked for questions in advance, and let me tell you, we got a lot of questions in advance. So we're already starting with a good place. Today's session is entirely going to be answering the questions that you have asked. But at the same time, you should have received a note card on your way in. And so that we ask you, if you have additional questions, please note them, put them on the note card you received, and then I will ask you at some point to pass those questions onto the side. We'll collect them and go from there. So we're going to get to as many questions as we possibly can. With that, I'm going to introduce our panel of international experts. So on my far right, Ranjit Manchanda, who is a clinical senior lecturer and consultant gynecological oncologist at Bart's Cancer Institute at Queen Mary University of London. And we're really lucky to have him with us today to talk also about his ongoing work related to population screening and how to think about that in the future. Gareth Evans is a professor of medical genetics and cancer epidemiologist at the University of Manchester and has one of the largest clinics, including BRCA1 and 2 mutation carriers, and has exceedingly long-term outcomes on those individuals. Both of them will be giving talks tomorrow, so if you're here, that would be terrific. And as you've heard, Kate Nathanson is the Pearl Basser Professor for BRCA-related research. She's also the Deputy Director of the Abramson Cancer Center, Director of Genetics at the Basser Center for BRCA. So with that introduction in mind, I'm going to take one question before I pass everything off to the rest of them. A question was asked about whether there's a difference in risk for people with BRCA1 versus BRCA2 mutations. And you notice that I just said BRCA1. You sometimes heard BRCA, and it's just a technical difference. The name of the gene is BRCA1 and BRCA2. There was a commercial test that was called BRCA, so we tend to, if you hear us use that phrase, that's why. But BRCA1 and BRCA2 mutations give rise to related but different susceptibility syndromes. So they don't look exactly the same. The risks, for instance, for ovarian cancer are higher in BRCA1 than in BRCA2 mutation carriers. The ovarian cancer occurs a little earlier than in BRCA1 than in BRCA2. And BRCA2 mutation carriers, BRCA2 mutations are a little more directly relevant to men because there is a higher risk of prostate cancer, which is an aggressive form of prostate cancer. There's also a higher risk of male breast cancer. And there is also a higher risk of pancreatic cancer related to BRCA2 than for BRCA1. We'll probably talk a little bit more later how the breast cancer is different between the two as well. So we'll try to, as we go along, differentiate when it matters between those two. But it is an important point, which is that they're not exactly the same. So here's the next question. This one I'm going to send to Dr. Evans. My family had multiple cases of breast cancer, but no one has a BRCA1 or 2 mutation or any other mutation that they can detect. Can you discuss ongoing research to find missing breast cancer susceptibility genes?
Yes, well, I can certainly have a go at that one. Over the last few years, there hasn't been a great deal of progress in finding other high-risk genes. PALB2 has recently been reclassified as a high-risk gene, and that is probably the next most important gene when we look at panel testing. One of the things that there's quite a lot of work on is finding, because we don't have a gold standard, we don't have a test that says that's a BRCA1 family, that's a BRCA2 family, and then we do the mutation testing, and we don't know that it's 100%. So recently we identified a variant in the 5' region, so before the start of the gene, that actually switches off the promoter. And these 5' mutations, is a recent paper just been accepted in Nature Communications that I'm involved with, seem to be actually quite important, and they've been overlooked. So there's a possibility that some genetic variants are being missed, like deep intronic variants that you'd have to do RNA analysis for. These wouldn't normally be picked up, but in fact, they're very, very rare in BRCA1 and 2. The ongoing research is initially concentrated on the big families to see if you could link to other regions, and then those families were used in whole genome sequencing to try and find new genes. But again, that's been relatively disappointing that there don't appear to be any obvious ones appearing at the moment. But there is still ongoing work, and I guess there is still the possibility of another high-risk gene, but it's likely to be extremely rare. And there is the possibility of further moderate risk genes. But probably the biggest element that we've found recently, and I think there's a poster here that partly addresses that, is actually testing for the very common genetic variants can cause quite significant clusters of breast cancer that look as though there has to be a gene there, but that could actually be just due to the distribution of these very common variants. And And these seem to be extremely predictive of breast cancer in those families that are BRCA negative. And so at least some of that pattern is likely to be due to inheriting a bad pattern of these common variants. So yes, there's further needs to be done. Most of the missing component, I think we're up to about, if you include the newly identified or SNPs or proxy SNPs, we're up to about 60% of the inherited component of breast cancer having been explained. So there's still another 40% to find. Most of that is thought to probably be due to more SNPs, more common variants, rather than new moderate and high-risk genes.
And so just a few kind of, if you will, translations, because, you know, the British English is a little hard to understand. So,
Like Welsh.
Even worse. So there's, when you mentioned the intronic, just as a reminder from high school biology that there's introns, which don't form coding sequences, and there's exons which do, and when we do sequencing, we generally just sequence
So the way I
exons.
tend to explain it to patients is that you look at a book and you're looking at the chapters in the book and looking for spelling mistakes, and actually the introns are like the binder of the book. We don't look in the binder. Now the binder is actually bigger than the book itself in terms of the number of letters, but there are massive amounts of DNA in between the exons, the bits that are read into the protein, that there is the possibility of variants within those that can completely mess up the code. And in fact, there are other conditions. NF1 is a prime example where there's a very high frequency of these deep intronic variants, which are very important in terms of analysis. And that's why RNA analysis is done in NF1, whereas in BRCA, actually, we have and various other people have looked at these introns and actually haven't really found much.
Right. So it may be rare, but important for the rare patient. Then just to follow up on the SNP, which is single nucleotide polymorphism, and each one only increases the risk just a teeny bit.
Teeny bit.
Yeah. How many are there now?
Well, there are over 150 actual SNPs that have been published, and then the latest paper was 313, which included these sort of proxy SNPs that are likely to be there. And if you drop the sort of significance level, then it looks like there are more there that just need more numbers in order to prove that they are actually linked.
Yeah, so any one doesn't matter really at all.
On its own, no.
But 100, if you have all 100 bad ones, then you start talking.
Yeah, you certainly are starting to get to, you know, a significant proportion of people are high risk based on just SNP analysis alone. So you're starting to get numbers who have a 30% lifetime risk or higher, which we use as the high risk definition. And I think for MRI, it's 20 to 25%. but 30% I think is real high risk. And you can certainly get there based on SNPs alone. But obviously, if you add SNPs to mammographic density and other risk factors in a model, you can get really significant numbers up into the high risk group. About currently, on a population level, we can get over 8% of the population up into that high risk category, whereas family history alone would only get 1%.
And just as a final quick comment, these SNPs may be applicable to individuals who have mutations in other genes, particularly these moderate penetrance genes, which only increase risk a moderate amount.
CHEK2 and ATM.
Things like CHEK2 and ATM. But that's an area of evolving research as well, which we may get back to. But Kate, I'm going to turn to you next. And so the question is, I am a BRCA carrier. Because of this, is it certain that my breast cancer was caused by my mutation? And how would you know?
BRCA1?
They said BRCA1, but you could differentiate. These are exact questions, by the way. Good questions.
All right, so it's a great question. So for BRCA1, we're pretty sure that your mutation is associated with loss of heterozygosity in the breast cancer.
Which means?
Which means that you lose the wild type or the normal allele. For BRCA2, we know that a slightly fewer percentage of people have lost the wild type or allele. Now, not having lost allele type allele doesn't necessarily mean that the BRCA2 mutation isn't associated with breast cancer, and that's sort of, I think, a big area of research, and it was an area of a lot of discussion, actually, particularly earlier today, because it may be that what we call the haploinsufficient state, that means carrying only one mutation in the cell without having lost both copies, only having sort of a decrement in function of one of the copies, may also predispose you to cancer if there are other insults or other things that happen. But we don't really understand that as well, and we're really trying to figure that out. I think it's tough for us to know the answer. Are there probably occasional people who have BRCA1 and 2 mutations who get sporadic cancer? That's probably the case. But how we figure that out and know the answer to that question is very difficult.
Right. So we used to have in our heads the sort of the classic thinking was you were born with one bad copy,
right,
and in the cancer the second copy was lost or mutated or failed to function anymore, and that's what caused the cancer. And it turns out, particularly for BRCA2, the story is somewhat more complicated than that, but nonetheless, the gene mutation certainly massively elevates your risk. Gareth?
So I would say that, particularly when you get down to genes like CHEK2 and ATM, where there's only a twofold relative risk, that means possibly half the cancers are not related. But I think there are potentially clues in the pathology. Grade 1 breast cancers are extremely rare in BRCA1. If you get a grade 1 breast cancer, that may well be a chance occurrence, because BRCA, the process by which BRCA1 causes breast cancer typically goes down a pathway which will not give you a low-grade estrogen receptor positive tumor. So there will be potential clues in the pathology, less so for BRCA2 because you get the whole gamut with BRCA2, but with BRCA1 because it so typically causes high-grade triple-negative breast cancers, a grade 1 is really rare and may well be a chance occurrence.
It's a great point. And so a follow-up question, Kate, is what is the likelihood that BRCA2 mutations can cause other cancers? For example, I'm a 36-year-old woman, non-smoker, non-drinker, and I was recently diagnosed with tongue cancer. So these are tough.
That's a tough question. So I'm going to actually talk about some data that's not my data. It's actually coming out of Memorial Sloan Kettering, but I've seen it presented, which is very interesting data. Which they really suggest strongly, and this is data coming out of their impact study, really led by David Sollett, Barry Taylor, and Ken Offit, who's here, has been very involved in these studies, suggesting that outside of breast, ovarian, prostate, and pancreatic cancer, that other cancers are not as related to BRCA1 and 2 mutations, and that most other cancers in patients with BRCA1 and 2 mutations tend to be, as we say, sporadic or happen by chance rather than be driven by the cancers. It's very interesting data, and it's, did I turn it off by mistake? Oops. All right, I'll put it down so I'm not playing with it. Very interesting data. It's consistent with some data that had been coming out of the TCGA and some other data sources, but at Memorial they have a very large sort of sequencing cohort that they've been able to look at for BRCA1 and 2 mutations. So tongue cancer, I think I'm going to say there actually was, particularly for BRCA2, some early data suggesting laryngeal cancer was associated. But I think that over time that hasn't really stood up as a big associated cancer. The problem is that with really rare cancers, you need so many people to develop a cancer to see it's really significantly increased above the population that it can be really hard to know whether it's chance or not. But I would say that the Memorial data is really suggesting that it's really the canonical prostate, pancreatic, breast, and ovarian that are associated with
Although it does depend what you decide the definition is of a BRCA-associated cancer, which seems to change all the time. Gareth, you had a comment.
So, one of the things we have to be careful of with these studies is a lot of the cancers have not been confirmed in the families. And particularly things like throat. What is throat? Is it larynx or is it esophagus?
Studies. Right.
And there is possibly a bit of a signal for esophagus, not larynx, which is... So that's an issue. Stomach is a big issue because certainly in lay terms, people tend to call stomach anything in the abdomen, and some of those stomachs we've gone back and found were ovarian cancers because obviously the abdomen distends.
But that's actually the great thing about the Memorial data is they obviously
it's
it's all
absolutely-
confirmed. Yeah.
But
But I don't know, I mean, again.
But there are, really, really rare cancers, and before people who are BRCA2 carriers go away thinking, gosh, I'm going to get one of these, they're still extremely rare, even if the risk is increased quite a bit. So ocular melanoma, I think, is one which is absolutely clearly linked, and there is a signal for skin cancers, including melanoma in BRCA2. And then we've got 4 liposarcomas in our BRCA2 cohort, and that's an extraordinarily rare tumor. And again, I think there's probably a signal there for liposarcoma. So I think because the really rare ones, you have to have tens of thousands of patients in order to really nail it down. No one's really been able to create those sorts of cohorts.
And as a reminder, if a risk doubles, but it was 0.01% and it went up to 0.02%, that doesn't mean we all have to go get screened for it.
Exactly.
And this is why, it's our job to kind of not only identify the risk, but then try to put them, in context of things. Okay, we haven't forgotten about you, Ranjit. So there were many questions, so I'm not going to give them verbatim, related to ovarian cancer screening and prevention. So can you start us off about ovarian cancer screening?
So we talk about the high-risk population because
we're going to talk about BRCA1 and 2
BRCA1 and BRCA2. If one is to screen for ovarian cancer in the BRCA1 and the BRCA2 population, then the best way to do it, or the way we've done it in the screening trials, which have been run in the UK and also in the US, is by doing a blood test called a CA125 blood test, but doing it every 4 months. And the US studies ran at 3 monthly. So every 3 or 4 months, not frequently. So doing a CA125 blood, CA125 is a marker which goes up with ovary cancer, but doesn't go up with all ovarian cancers. It goes up in about 85% of ovarian cancers. Doing it once a year does not work. Doing an ultrasound scan just to screen for ovary cancer doesn't work. The key thing is an assessment of the marker on a longitudinal basis. That means analyzing it over a period of time and looking at the change in the level of the marker rather than just what the marker level is in itself. So it's the change in trend in the marker that can give you an idea whether there's an early cancer or not. So there are sophisticated algorithms which have analyzed it like that. And the UK, the US studies use something called the ROCA algorithm. But there are other algorithms which have also been published, some from the States and even other algorithms which come from the UK. It's the concept, I think, of looking at it as a longitudinal change over time that's really important.
Now, ROCA is not available, though. I mean, that's not a...
So does ovary cancer screening save lives? The answer is that that's not yet proven to be the case.
So to be clear.
So it's important to mention the low-risk population studies because in the BRCA1 and 2 population, that's a question we can't answer because the study is not designed to answer that. In the lower-risk population studies, it has not been shown to do so. There is an inkling of the possibility of a signal in the UK study, but we're not certain, and therefore it's currently being followed up for the next year and a half, and maybe in 1 or 2 years we'll have a more definitive answer, but at the moment whatever data there is suggests that that's not the case. Can we pick up a lot of cancers by screening in the BRCA1 and 2 population? Yes, so that means there's high sensitivity. Do we have good ability to say you don't have a cancer if the test suggests that? Then is there high specificity? Yes, so that's reasonably good. The problem we have is that we still don't pick up a large proportion of cancers early enough. We can pick up about maybe 40-50% cancers early, but still a large proportion of the cancers present late. But one of the things we have found in the recently published data from the screening study was that if women were not having screening, then 95% of the cancers were picked up late. So you do significantly pick up a larger proportion of cancers early. The other philosophy we have now in ovary cancer surgery, I'm a surgeon, so I have to talk about surgery.
I was getting it. That was my next question.
Is that the concept is to do more radical procedures, longer operations to try and get rid of all the disease we can see by the naked eye, or called macroscopic disease, means anything we can see we want to remove. And it's the ladies in whom we can achieve that who tend to live longer than in those whom we don't achieve. And what we do find is that the women who have been on the screening studies, that's found, there's almost a 95% chance that you will achieve being able to debulk or remove all the disease you can see in women who have been picked up with cancer on the screening study, which is higher than what you would if you were not on the screening study. So that's the literature of the data there.
Right.
So in the UK, I don't think that there is a strong recommendation for screening in BRCA1, the BRCA1 or 2 is still very ambiguous the way it's drafted in guidelines.
That's why I was going to ask Gareth, what are the NICE guidelines? Do they?
Actually, there are no NICE guidelines for ovarian screening.
And then actually the NCCN doesn't
So we are in the
assertively recommend it. Yeah.
We are in the UK running a study at the moment called the Aldo Study, which is the same as the high-risk screening study. It's a different name and a badge. It's called Avoiding Late Diagnosis of Ovarian Cancer. In this, I think it's an interim measure as we collect more data and we wait for the larger population screening study, which is in the low-risk population, to report before everybody can come to a consensus on whether this goes forward or not. So that's the state of play at the moment.
But alas, I mean, and not the reason for the very strong recommendation about oophorectomy for BRCA1 and 2 is because in the end, we don't pick enough, even with screening, we don't pick up enough of the cancers early. Would that be an accurate statement?
I think screening is early, trying to pick up a cancer early, which we're not very good at. Does screening have value in women who do not want to have the tubes and ovaries out is a different question.
Yes.
And there's possibility in the BRCA1 and the BRCA2 population. Without ambiguity, the best way to prevent ovarian cancer is to have the tubes and ovaries out. And if one is looking at it from a prevention point of view, or point of view of minimizing your risk, if I rephrase that, then prevention is the best way to minimize risk. And it's different. It's not screening. You don't want the cancer in the first place. And that's better than trying to pick it up.
Great, and that's very helpful. So I am going to change gears a little bit because there were multiple questions about timing of testing for BRCA1 and 2 mutations when there's a known mutation in the family, meaning to summarize it, what age should my daughter get tested? And this is actually where it's always interesting country to country because, Gareth, you've already referred to the fact that guidelines differ between countries even with initiation of screening. So, Kate, what do we say to people in the U.S. about when we start screening? You know the answer.
We start screening at 25.
There you go. Well,
so you get tested.
So we tend to test at 25, but I think that you're
So
a little different.
it is changing. In fact, it's not yet out, but the breast screening in BRCA carriers is actually done through the National Health Service breast screening program. And it used to be starting at 30, but it has now changed that if the 10-year risk is 8%, you can start when the 10-year risk hits 8%. So really anyone who has a first-degree relative under 35 who is carrying BRCA1 or BRCA2 is going to hit that 8% at 25. So I think that gets you around. It's a nice sort of reasonably clever way of getting those people who are at significant risk under 30 getting their screening in at 25. So I think people tend to go for the mutation testing, the pre-symptomatic testing, when there's something they can do about it. Now, some will even decide they want risk-reducing mastectomy in their early 20s. Some will do it to initiate their screening, but there's a very substantial body of women who really don't want to know in their early 20s. And it might be that they'll decide when they're thinking about children. But, if there's nothing you can do about it, if you're a worrier, and you're not going to have a mastectomy, then it's a difficult thing to make yourself go through a 10-year period where you've got this gene fault and you're not going to be doing anything about it.
Well, as a follow-up question, go ahead.
I can have a comment on that. my understanding, the legal age of testing or offering, being able to offer it is that it's 18.
Correct.
So just to make that point.
Yes. And
I think
that's the
apart
follow-up.
from mastectomy and screening, there's the whole issue of contraception, reproductive health, lifestyle choices, planning a family, which also goes into one's decision making as one goes through life. And there are, so it's horse for course, it depends on what women would like or men would like to do. And there are some women who may want to know at an earlier age to be able to do that. From a contraception point of view, I'd rather someone took it at an earlier age where the absolute risk of breast cancer is lower in case there was a breast cancer impact with the contraceptive pill. And you can reduce your risk of ovarian cancer if you took it for 5 years.
Right.
So
Although-
there's those bit of decision making to go.
Yes, although I would sort of push back in stating that, the risk of ovarian cancer goes down with birth control pills, but the risk of ovarian cancer might ever so slightly go up. And so usually breast, would I say? And so if you will, I often talk to people about, birth control pills do great things like prevent pregnancies and help with cycle regulation, and they do other bad things like and reduce ovarian cancer risk, and they do other bad things like slightly increase your risk of blood clots. So the question is, at 18, do you need to know your mutation status to make a decision about birth control pills? And I think we felt that we don't, and so that particular thing isn't a reason to test. That comes up all the time because we get questions, from moms who understandably are worried about their 16-year-olds who are thinking about going on birth control pills. But PGT. So let's talk about pre-implantation genetic testing. So Gareth, you want to take that one on? Or Kate, you
it's in the
define it. Sorry.
So pre-implantation genetic testing is where you create an embryo by in vitro fertilization, and you basically let that embryo grow to a cluster of cells, and then you can take a few cells off that cluster, which the moment we don't think is damaging long term to that embryo and future child, and you test that little cluster of cells for the genetic mutation that has been identified.
So I'm actually going to stop because I actually want to clarify. It's called a blastocyst.
It's a blastocyst.
So it's not an embryo, it's a blastocyst.
Yeah, okay, a blastocyst.
And it's a...
This is what happens when you get two geneticists sitting next to each other. They can argue about this. Yeah.
Right. And so I just want to because I'm sure you talk about PGD every day, and I talk about PGD every day. So it's a blastocyst, and then so in fact the way it works, I just want to actually be clear because people don't know, is it's like in vitro fertilization, essentially, but you actually only inject one sperm because you can't so you actually take the egg, you inject one sperm, it gets to about the 8 to 10 cell stage, so blastocyst, and you take one cell out, and actually that cell that you take out gets amplified and tested for the mutation. There's a lot of experience in the U.S. doing, there's different kinds of pre-implantation genetic diagnosis. So not only for BRCA1 and 2 mutations, people do this for all sorts of inherited genetic mutations. And they also, you can do PGD to look at chromosomal differences. So as you get older, you're more at risk of having chromosomal differences. And so they sometimes will combine things like PGD and chromosomal differences so that you make sure that you know when you go back to implant the blastocyst back, that it gets to about the 16 cell stage.
It may be a bit of a semantic difference.
But I just want to make sure we're clear on how many cells are there, right? So about the 16 cell stage.
Just so you know, I say embryo in the clinic because it may be a little bit more.
It's done later.
It's done early in the
Done later. And they do take more than one cell
That's
now.
interesting. That's not the way,
So,
There you go.
it's obviously different.
That's it. There you go. Okay.
Right.
Another question. The specific question was, is there anything that a child could do? So meaning, is there a reason to test a child? I mean, I have an answer to this, but, why test children?
So I'll say no, and I would say that we have data certainly that shows there's no increased risk of pediatric cancer.
To the limited, so what we have.
Yeah.
And Gareth, have you
No,
looked
I agree with that.
to-
There's no convincing evidence that there's an increase in pediatric cancer. The only where there is where you get two faulty copies of BRCA2 in particular. It's extraordinarily rare. where you get 2 faulty copies of BRCA1, it's almost thought to be almost always lethal as an embryo. But a proportion with 2 faulty copies of BRCA2 do survive, and they have a high risk of pediatric cancers, but not with a single faulty copy. And in fact, we do allow testing 16 and 17-year-olds if both the parents and the young adult consent to testing. That's the earliest we will do testing is 16, because at 16 you're allowed to have children. So if you're allowed to have children who inherit your BRCA1 genetic fault, or BRCA2 for that matter, you should, I think, be able to decide to have the genetic test with joint consent, but it has to be joint consent.
I mean, in general, the U.S. is 18, but, you know, if a 16-year-old came to me wanting to have kids, I suppose I'd change my mind, but I haven't had that happen yet. So, all right, so getting on to less controversial topics. So, Ranjit, can you tell us a little bit about PARP inhibitors and ovarian cancer, and, you know, how they've been helpful to you?
So, I'm not a medical oncologist.
Ah,
but I
you
still
can
do my
pretend
best.
one. Yeah.
So PARP inhibitors have been shown to improve survival in treating women who have ovarian cancer, women who have BRCA1 or BRCA2 gene mutations, either ones which they inherit or ones which may happen in the tumor tissue but they may not inherit. So the change in the tumor tissue but not in the germline or something that they inherit and pass on. Frequency in ovary cancer, depending on it's about probably between 10 and 20%, with going up between 1 in 6 to 1 in 5, I'd say. Another half of those may be just faults in the tumor tissue. So when we're treating women with ovarian cancer, it's very helpful to know the status of BRCA1 and BRCA2 genes, not only in the germline or the inheritable component, but also in the tumor tissue. And the initial data which came out from studies was done in women in whom the ovarian cancer had recurred and who were sensitive to a medicine called platinum, which is a standard medicine or drug used to treat ovary cancer. And it was shown to improve survival in them. The more exciting bit is the literature which has just come out, a study which is recently published at the end of last year, which shows that it can be used upfront as soon as women have finished the chemotherapy in the first line setting as a maintenance. That is, as soon as you finish your chemotherapy, you can have PARP inhibitor treatment. And women who've had that, it was shown to significantly reduce, to improve what's called progression-free survival, or the time before cancer comes back. And the impact was quite high, and the whole medical oncology community is actually quite excited about it, because after a long time, the platinum and Taxol, which are the 2 common medicines used to treat ovary cancer, have been around for a very long time, and there's not been something as exciting as as PARP, which has come up in this setting, and so the 70% reduction of the chance of the cancer coming back. So it's exciting. I think still not common practice in most institutions, I would say, at least in the UK, maybe in the US. I don't know, to do both tumor testing and the germline testing. We do it in our center. I think Gareth does it in their center, but most centers in the UK don't do it.
Right.
Uh,
But I do feel that is really important.
Yes, I completely agree. And so since 2014, there's been multiple PARP inhibitors that have been approved by the FDA. I don't know what the status is in the UK, but so we have, for ovarian cancer, there is olaparib, rucaparib, and niraparib in the US. And for BRCA-associated breast cancer, there's olaparib and talazoparib. So that's really pretty amazing that we have all of these ways to treat BRCA1 and 2 related breast and ovarian cancer. And again, the first line maintenance setting is really, these are patients who potentially were curable, but were at very high risk for relapse. And this is making many more of them, at least for now, not relapse. And so there's an ongoing study for breast cancer, for BRCA1 and 2 associated breast cancer, where the 1,800 women with sort of early stage BRCA1 and 2 associated breast cancer. Half get the PARP inhibitor olaparib, half get a sugar pill. So we'll see how many of those, what effect there is on that. That study just closed to accrual, so we'll be waiting for the results. And there's been really exciting data in pancreatic cancer, both for rucaparib, and at ASCO there'll be presentation on olaparib, and Gareth has a further comment.
No, it's just a general comment that actually when we trial these drugs in the first instance, it's often in advanced disease. So,
Right.
so the initial licensing for was after second relapse.
Correct,
So,
yes.
so you're already in a situation where you're not necessarily thinking about cure, it's more prolonging life. And for instance, Herceptin came in initially in that advanced disease stage, and that wasn't saving lives. It's only when it was brought up front that Herceptin has revolutionized treatment of those who have HER2-positive breast cancers. Unfortunately, that's pretty rare in BRCA1 in particular. But this is really exciting that the PARP inhibitors are now coming up front, because that is, I think, where they're going to start saving lives.
Absolutely, I completely agree. So Kate, I have a question for you, and then we're going to get to prevention. So, except that Beth has given me the flag, so we're going to start collecting cards. So if you pass them to either side, people will pick them up at the ends. All right, so Kate, a question about, and it was already alluded to, about somatic mutation. So I'm just going to define this. If you're born with a bad copy in all your cells, we call that a germline mutation. If only your tumor has a bad copy of BRCA1 or 2, that's somatic. And so, the one question, Kate, is how do you get a somatic mutation? And then, I'll ask Gareth, does it matter for treatment purposes whether it's somatic or germline? So Kate, you first.
So getting a somatic mutation means that you have a mutation that's in your tumor. I'm debating how far to go here. So
Shorter's better.
Shorter's better.
Yeah.
So I think that one of the things that I think is more fascinating, and I think has really been better understood recently, is there's multiple ways that we have mutations that arise, and that probably all of us are somatic mosaics for different mutations, and so that we've always thought about sort of somatic mutations as being limited to the tumor, but it's probably true that each of us has at least 5 and maybe more different mutations that we've acquired after the egg and the sperm have come together during early embryonic development that are
You're not going to say blastocyst, are you?
No, I was just going to say embryonic development. I just want to be super clear because I worry that embryo
It could have occurred at the
blastocyst
occurred at the blastocyst stage. But I just want to be clear. I just want to be very clear what stage we were talking about. Anyway, so during embryonic development, we're probably all acquiring actually different mutations. And so sometimes if you have a mutation in a tumor, it actually may be a mutation that you acquired sometime actually during embryonic development that gave you that heterozygous state in that particular tissue that led to a tumor. And I think we're really starting to understand that. But in general, we think about it as sort of limited to the tumor.
Right.
But I think that we're going to understand more and more about that.
And should it affect response?
So I think there is a feeling it does, because when you have one faulty copy that you've inherited, all your cells will have that. And there is a concern that some of the somatic variants that are identified are at quite low allele frequency in the tumor. And that may mean that the tumor may gain resistance. So it'll kill off the cells that have got the BRCA1 or BRCA2 somatic variant, but then there may be survivor cells that are resistant. So the feeling is, and I think the drug companies are aware of this, is that those ovarian cancers with somatic mutations, somatic variants, are possibly more likely to develop resistance.
So the interesting thing, and if we can get cards over here too, the interesting thing though is that somewhat surprisingly, the olaparib first-line maintenance, even though very, very few patients in the study had somatic rather than germline mutations, exactly to Ranjit telling me, the drug was approved for both. And so I think that at least in ovarian cancer, there have been multiple patients who have responded despite somatic mutations only, but your points are well taken. We don't have a ton of data. I'm going to move to, there's 2 main topics I want to touch before we to get to the other cards. So the first is, and Ranjit, this one's coming right for you. Quote: "Should everyone get tested for BRCA even if there's no family history?"
Yes.
Feel free to get on your soapbox now. Yes. Yeah.
Yes, I believe so. However, what do the data suggest? So I think there are populations in the world where we see BRCA1 and BRCA2 genes more frequently. They're called founder populations. An example is the Jewish community. But there are other communities also. You see them in the Finnish population, the Polish population, the Icelandic population, and so on and so forth. So there have been studies which have offered testing for BRCA1 and BRCA2 genes across the Jewish population. There have been studies which have been run, we've run one in the UK, they've been in Israel, it's been in Canada. You have one ongoing in the States at the moment, and there's one running in Australia. And they all show that we pick up far more people at risk if we offer the testing to everybody. We believe that about half the people do not fulfill the criteria for testing, and you will miss these people if you don't offer testing to everybody. So if the idea is to maximize prevention and identify more people at risk so that we can prevent more cancers, then without ambiguity, offering the testing to everyone will do that compared to what we do clinically today. In the Jewish population, there's good data to show that it's feasible, it's acceptable, it's safe to do. We're not doing any significant harm from the point of view of impacting quality of life or psychosocial well-being. And it is cost effective and potentially cost saving in most scenarios. So I do believe the time's come to change policy for testing in the Jewish population or founder populations. And that the guidelines haven't followed suit, and there's no health system in the world today that allows us to do that, unfortunately. From the point of view of offering testing beyond the Jewish population to the more wider general population, again, I think there are a number of limitations of our health system today. We have complex criteria which have gradually changed over the years. So whether you look at the criteria in the US and the NCCN criteria, or you look at the UK criteria, the thresholds 10, 15 years ago used to be high, and they've gradually fallen to broaden the base and access to testing. Initially, I mean, this is my view, may be different. Others, a lot of it was driven by cost and logistics. So two things have happened. The technology to test people on a large scale is there, and the costs have fallen drastically. Access to testing is still limited, and there's huge underutilization. Most people who carry a BRCA1 and a BRCA2 gene mutation who could access prevention have not yet been identified. Our analysis of data from a London population suggests only 3% have been identified since testing began in the UK. 97% remain unidentified. If we are to use technology to maximize prevention and prevent these cancers, the way around it and to improve uptake is to offer it to everybody. It doesn't mean everybody needs to have it, but they can have the option to make that choice, and we'll definitely prevent thousands more cancers than we do today.
So I
if
think
it's available.
Right. So I think
there's no data to show, there are no studies or implementation studies for the general population. And I think there are lots of other issues that need to be addressed before we can go out and implement it in the broader general population. You know, it's handling, how do you do it, how do you handle it, there's VUS, there's a host of other issues that need to be addressed. But in the Jewish context, it's...
And just so we did have a one-day think tank yesterday, you know, again, involving people from the US, Australia, Israel, Canada, to try to figure out, a lot of this is about implementation. A lot of it is actually how do you do it. And so a lot of us are working on different things, digital health platforms. Dr. Offit will be talking about that more tomorrow. So we're really down to the brass tacks of actually how would you get this done, because even if you flip the switch tomorrow and you said go ahead and do it, you actually have to wait, you have to have a way to do it. And I think that's where we have it. Gareth, you had a comment.
So I think it's really important to have the distinction between founder populations and doing testing in an outbred population like the United States or the UK, and the whole population. Firstly, you've got a definite yes/no answer. You're testing just for 3 founder mutations, and you either have them or you don't. And in the Jewish population, those account for probably 95% of all of the involvement of BRCA1 and 2, which is probably as sensitive as the tests we have for the whole of the gene in the outbred population. And the problem then is that actually only about 3 or 4 in 1,000 will have a BRCA mutation in the outbred population. And 10 times that will have a variant of uncertain significance. So at least, well, it depends, Myriad will be able to get it down to about 1.3%, but they have more data. Most labs in the UK, for instance, are still quoting about a 4 to 5% variant of uncertain significance risk. Yeah. So I think you have to decide that you ignore those, because the problems with actually trying to explain what a variant of uncertain significance is in population testing will be impossible. It will make it unfeasible.
Right. Yeah. Well, as will adding tons of other genes, which is another problem we're having. But Gareth, I wanted to ask you a follow-up question because someone asked specifically, for people with BRCA mutations and no family history of cancer, is the risk profile the same if you find a mutation, particularly for BRCA2? Let's
right. Well, no, it isn't. And even for BRCA1, there is some modification. So your family history is a surrogate for other genetic factors. So if you have a very strong family history of early onset breast cancer, you've probably got other factors in that family, genetic factors that increase the risk of breast cancer. And there are many studies, we've shown it, the Cambridge team has shown it, other people around the world have shown it, that if you have a strong family history of breast cancer, your risk if you inherit the BRCA1 or BRCA2 variant is higher, and it's particularly for BRCA2, which is a more malleable gene in terms of the risk range. And a lot of that is now predictable by doing SNP testing, variant testing.
Those things we talked about before, the little tiny ones.
We talked about earlier, these multiple common variants, that we can now much better predict breast cancer risk on the basis of those multiple SNPs in BRCA1 and BRCA2. So I think the future will be that we will include family history and the SNPs in being able to give people a much more accurate idea of where their risks lie in a range for BRCA2, which might go as low as 30% up to 95%, and for BRCA1, probably 40% up to 95%.
And mammographic density.
And mammographic density as well.
Right, we're going to now do the rapid fire session of the evening because you guys have asked such incredible questions. So, Kate, if you and your husband both have a BRCA mutation, we're going to decide for the moment that one's BRCA1 and one's BRCA2 to keep this easy. What are the odds that your children will have a mutation?
If you're, so I'm like doing the Punnett square in my head.
Yes,
you are. So each child has a 50% risk for both mutations. We know that you can have both a BRCA1 and a BRCA2 mutation, but your risk actually is not, just to say it's not elevated. It turns out that if you have both a BRCA1 and 2 mutation, your risk is about the same. It goes with BRCA1. And so I would say it's 3/4 chance that you each, 3 out of 4 children will carry a mutation. 1 out of 4 children will not carry a mutation based on hopefully they independently segregate. And 1
out of 4 will be both.
And 1 out of 4 will be both. So that's actually 2 out of 4 will have 1 mutation, 1 out of 4 will have 2 mutations, and 1 out of 4 will have no mutations. But that chance, to be clear, is independent for each child. So what you have for one child is not predictive of what happens for the next child. Yeah. Just to be 100% clear on that point.
And again, we're happy to discuss this more
so
afterwards.
For BRCA1,
right? Yes, go ahead.
It would be 2 in 3 because the fourth one is embryonic lethal.
Except for
there might be a slight, except for incredibly rare.
Case report, yes.
So,
and BRCA2.
And for BRCA2, it depends on the variants.
That's right.
That some are predicted if they can, well, we still don't know the full story, but if they're completely null alleles and there's no function of the product, then it's thought that those are lethal. But where there is some escape and there is some BRCA2
like a splicer
function remaining,
mutation.
then you can have this risk of Fanconi anemia where you have two faulty copies. So it's not so straightforward with BRCA.
This is why genetic counseling is important, and whoever put in this question, feel free to approach us at the end. But yes. So is it acceptable to do breast surveillance? Gareth, I'm going to put that to you.
Is it acceptable?
Rather than a mastectomy. If does
so
everyone need a mastectomy?
I will say, and I'll present data tomorrow if you're there tomorrow, that actually a combination of MRI and mammography annually is extremely effective at pricking up breast cancer at a very early stage. And there is probably only a very slight survival advantage from having a risk-reducing mastectomy. The problem is you have to go through all the worry of each time, is this the time I'm going to get cancer? And also the fact that you're going to have to, particularly with BRCA1, having to go through chemotherapy with virtually every BRCA1 cancer, however small it is, even a 2 millimeter grade 3 triple negative breast cancer in the UK, if you're BRCA1, you will get chemotherapy.
We're not quite,
okay.
But quite that far.
But
yeah.
So it's a choice. And if you explain that actually it's not going to affect your life expectancy that much, and as I say, I'll present our data on over 880 women who've tested positive without cancer at the time of testing positive, and it really is extremely good. But it's not 100%. We can't. It's probably, if you do really good screening, you've got well over a 90% chance of being cured of your cancer, probably near a 95%. And that's why there is not a massive survival advantage. But for ovarian cancer, you haven't got that benefit. And ovarian cancer is the real killer in BRCA1 and 2, and the one where it really drives life expectancy.
And another thing just to emphasize that Gareth and I were talking about, if you are identified as having, for instance, a BRCA2 mutation and you're 65 and had never had a cancer, your risk of developing cancer over the course of your lifetime is actually relatively low, sort of 20% or less. Mm-hmm. So it depends on your age. It depends on whether you have a BRCA1 or 2 mutation. It depends on your preferences. So there's a lot of pieces to this puzzle that go into the discussion about mastectomy versus screening. I'm going to do a quick one. What is the response rate of a Parp inhibitor in metastatic BRCA2-related cancer? BRCA1 and BRCA2 mutation-associated breast cancer in all the clinical trials that have been done, similar response rates in the 60 to 65% range. And again, those are all cancers that have seen chemotherapy at some point before, usually in the adjuvant setting, but still those response rates are pretty good. Nonetheless, most of those cancers at some point then start to grow again. So we're working on all sorts of things, combinations with other agents, potentially immune therapies, to see if we can make those better. So I want to actually hit on the topic of prevention because a lot of these cover this. So Ranjit, I don't know if you want to, and again, rapid fire time, salpingectomy only. Thoughts?
Okay.
In 5 words, no. And what is that?
The best way to prevent yourself from getting ovarian cancer if you carry a BRCA1 or BRCA2 gene mutation is to remove both tubes and ovaries. There's no ambiguity about it. That's what the data are based on, and that's what shows will save lives. There is an appreciation and agreement and understanding, and most clinicians and researchers believe that a large proportion of these cancers are coming from the tube. As was alluded, whether to undergo preventive surgery or not is a complex decision-making process. It's not a straightforward decision, and you need to weigh up the disadvantages or the cons of having early preventive surgery include going into early menopause, which has detrimental long-term health consequences. So a number of women may wish to delay or avoid early preventive surgery for that reason. So for women who do not wish to have an oophorectomy or removal of the ovary before they go into the menopause, an attractive proposition may be to have a 2-step procedure, which is to remove the tubes in the first setting and then the ovaries in the second setting, as they near the menopause, or definitely when they hit the menopause. And in that way, you may prevent a certain proportion of cancers compared to the fact that you would not have had anything done. Yeah. To precisely say what proportion of cancers would be prevented, I don't think anybody has answered that question as yet, and that's unknown. So we don't have a good precision on the estimate of how many cancers we'll prevent. If one looks at the data which comes out from BRCA1 and 2 women who've had preventive surgery, then my understanding of the literature is that 7 in 10 of these cancers, or these early cancers we pick up, are in the tube, and 3 in 10 are not. So maybe that's the level of prevention we may get. I don't know whether it's more or less.
I think it's really exciting.
So
but
it needs
should
to
be done
be
on a
the
study.
context of a research study, yes.
Right, yeah.
I'm uncomfortable. I would not advocate it outside the context of a research study.
Because we really, really, really want it to work, but we really, really, really are not sure yet. And we're stuck in this position seeing patients of, we really don't want to be wrong about this. And so trying to gather as much data as we can would be helpful. So Gareth, I don't know, do you want to say anything about denosumab?
Yeah.
Great.
So the really promising agent, particularly for BRCA1, is something called a rank ligand inhibitor. So this is a drug called denosumab, which is used to be used for treating osteoporosis, and in fact these drugs are starting to come back in to prevent metastatic breast cancer. But there is a lot of really good biology that suggests that this is a really vital pathway in early development of tumors in BRCA1 in particular. And so there are fairly advanced plans for an international study. I think Judy Garber has got a grant in at the moment with the Department of Defense that is now in its sort of
fingers crossed stage.
Yeah,
yes.
Fingers crossed stage.
Yeah.
And this will mean a 6-monthly injection, so not having to take a pill every day, that has almost no side effects. The main side effect is something called osteonecrosis of the jaw, which really
by the way, doesn't sound too good.
But it really only happens if you've got really bad dentition. So if if you're a young person with reasonably good dentition, the risk of that is tiny. And actually, the doses they're giving in this study are so small that they're probably not going to do that. And a question mark is whether they are too small. But this is the treatment that we really hope is going to have an impact in BRCA1, both for breast and ovarian cancer. For BRCA2, you do have tamoxifen, and almost certainly tamoxifen is going to be active. It's probably going to be a 40% reduction in breast cancer risk in BRCA2, although there is no good direct evidence of that. But there is another treatment that is looking quite promising, which is anti-progestogens. Right. And there's we've got some really nice work using allopristol acetate, doing breast biopsies before and after treatment, showing that it literally switches off the breast epithelium. And that may work as well in BRCA1.
Oh, that's interesting, yeah.
So it's very promising. The important thing is everyone thinks it's just estrogen. It isn't just estrogen that causes breast cancer. In fact, estrogen-only HRT, it does not convincingly increase breast cancer risk. It's the combined. It's both these things working together that's the problem. One or the other probably isn't a particular risk factor. And in fact, there are some studies that estrogen only reduces risk.
Right.
So that's the other new kid on the block that may be a runner for prevention for BRCA1 and 2 in the future.
So we've got denosumab, we've got hormonal therapies, including novel hormonal therapies, and then sort of 2 other ones just to mention quickly. We've talked about PARP inhibitors, and right now they're not really being studied for prevention until the safety profile is fully elucidated by the trial that I mentioned. But if that study shows that the patients who get the PARP inhibitor, again, we have 900 people who will get a PARP inhibitor, and if the safety profile looks good, I think that will be back on the table. Absolutely. It was on the table before, it was sort of shelved due to concerns about toxicity, so that may be one. And then we are working on immune approaches, vaccine approaches. I think that what we've learned in the past 10 years about the immune system is that it can be very good at about treating cancers, and let's try to use it to prevent them as well. So that is a study that we've done in early stage patients, and now we're still working on we're almost done with the IRB protocol, but we're going to try to take it into healthy BRCA1 and 2 carriers and look obviously very closely at safety. So I think there's a lot of interesting, exciting things coming. One of the questions in here was, should I have a child what are their options? What options will be available for my child if they have a BRCA mutation? And I can just tell you that all of us in the room are very determined that there will be other options available besides surgical ones for that child. So you have our word on that. We're working on it. So. So, I have so many questions here. So what I'm going to tell you to do is, because we have 1 minute left, is that I didn't answer many of them. So you can come up and talk to me after the session. But at this point, I'm going to invite, now I'm trying to remember who I'm inviting up. I think I'm inviting up Dr. Epstein. Thank you, John, for giving me the little heads up for final remarks.
I'm John Epstein, the Chief Scientific Officer here, and I just want to, for all of us, thank our panel very much for a great discussion. We heard a lot of terrific science today. We heard about these BRCA proteins that are like large scaffolds that assemble lots of other proteins around them to catalyze activities around damaged DNA that allows cells to survive normally, and in the absence of that activity, obviously, cancers can form. And like those large scaffolding proteins, the Basser Center has become an area of catalysis, a center where people are drawn together to share information, not just here at Penn, but around the world, with platforms that are built to help people share information, with events like this great symposium, leading to FDA approvals of drugs for the treatment of the disease, leading to foundational new scientific discoveries that we think will lead to new therapies down the road. And it just fits as a platform, I think, perfectly in the culture of Penn, because I think we're most proud here amidst great new buildings that are rising up, a beautiful new hospital rising next door, these buildings that we're enjoying today. I think we all appreciate that what's really important are the people that are here. And Susan, you do an amazing job at leading this very impactful thing.
Thank you.
I think you set the example that we're here not to beat out our competitors, to scoop somebody else, to have a win. We're here to cure diseases. And we're here to do that with all of our colleagues and partners, with our friends, with our donors, with our patients, so that we can make a difference. That's what we're all about. And Sherry and Len, I want to personally thank you for all you've done. Mindy, you and John have just catalyzed all that's happened here. We're very proud of what's going on. It's a time of great success in cancer. We've got a lot of work to do, but we're all very optimistic and excited about it. Thanks, everybody, for your time.